I, Dr. Snehal Mujhala, Cluster Medical Head, welcomes each one of you all to this most awaited international speaker program, which is focusing on the use of Romosozumab in the management of osteoporosis, a silently progressing metabolic disease that leads to the loss of bone mass. Well, as we gather here today, it is important to recognize the profound impact that osteoporosis and fragility fractures have on public health, particularly in India. Well, osteoporosis and fragility fractures are indeed a rampant health problem in our country. Shockingly, more than 4.5 million women above the age of 60 years suffer from a fractured spine, and more than 250,000 people sustain a hip fracture every year. Well, these statistics paint a stark picture of the challenges we face in addressing osteoporosis and fragility fractures within our population. Given the demographic trend, it is evident that fragility fractures and osteoporosis are poised to become a priority for India's healthcare system in the coming years. Against this backdrop, today's program holds immense significance. We have the privilege of hosting esteemed experts who will share their insights and expertise on the use of Romosozumab, a promising therapeutic intervention in the management of osteoporosis. Well, before we commence with our sessions, I would like to extend a warm welcome to our moderator, that's Dr. Ambrish Mittal, who will be guiding us through today's program. With his immense wealth of knowledge and experience, we are certain to have a stimulating and informative discussion ahead. Well, it's my privilege to introduce and welcome Dr. Ambrish Mittal. Dr. Ambrish Mittal is the Chairman and HOD of Endocrinology and Diabetes at Max Healthcare. He has a vast experience of more than 30 years. Dr. Ambrish Mittal is been awarded by the Padma Bhushan and the B.C. Roy Award. He also the Boyframe Award of the American Society for the Bone and Mineral Research. Also the World India Diabetes Foundation Outstanding Achievement Award. Dr. Mittal is also a fellowship recipient from the Harvard Medical School and the Japan International Cooperation Agency Fellowship of the ASMBR 2021. We welcome you, sir, and over to you.
Thank you very much for the very kind and warm welcome. It's a pleasure to see our panelists from the US already logged in and all waiting. And it's a pleasure to be with my colleagues from across the country, eminent experts who will be involved in the panel discussion. It's an honor to introduce Professor Felicia Cosman, who is a professor of medicine at Columbia University, New York. We all know about her. We all know, we've read her studies on, most recently on oral PTH, if I may say so, and so many other areas. Very interesting CV. We don't need to do too much discussion about her, except for the fact that she's also the winner of the ASBMR Barter Award for Clinical Research, one of the most respected names in clinical bone and mineral research across the world. And of course, Professor Paul Miller, who is Distinguished Clinical Professor of Medicine at University of Colorado Health Sciences, again, one of the most experienced and senior investigators in the field of bone and mineral metabolism, and has numerous publications, a lot of awards. I won't go into that, but clearly one of the leaders in the world on clinical trials in this area. So we have two really outstanding people. And what we have in India is a changing scenario. Osteoporosis as a specialty or as a disease was hardly recognized till late 90s when the Indian Society for Bone and Mineral Research was set up. And gradually that picked up, but only really got impetus when more and more orthopedic colleagues got involved, because they are the ones who primarily treat these conditions, although the society was driven largely by the endocrine fraternity. We started off with just alendronate, then risedronate, and then intravenous zoledronic acid made a big splash. Teriparatide somewhere along the way, again, initially very expensive, but now prices have really gone down, and therefore it's become much more accessible. And of course, the game changer, denosumab, that came in a few years ago with the ease of administration and astounding clinical data to back it up. So we've all been sort of big users of denosumab in the last few years and eagerly looking forward to the new anabolic agent, Romosozumab, which we don't have clinical experience with, but have read a lot about. So I think there can be no one better than Professor Cosman and Professor Miller to take us through the journey of Romosozumab, people who have used it in clinical trials and clinical practice, and enlighten us with their wisdom about this exciting new molecule. I request Professor Cosman to, no, I can't say take the stage, but to take over and deliver her address.
Well, thank you so much for that lovely introduction. And it is indeed a pleasure to be here with Dr. Miller and with our erudite Indian colleagues to celebrate the approval and the marketing, the launch of Romosozumab in India. So what I'd like to do is to talk about optimizing bone health for the very high-risk patient and, of course, the role of Romosozumab in that. And these are my disclosures. Romosozumab, as you know, is a monoclonal antibody which blocks the action of sclerostin. Sclerostin itself is an osteocyte protein that binds to the LRP5/6 receptor on osteoblasts and osteoblast precursor cells and inhibits Wnt signaling. As a result, sclerostin reduces formation, function, and survival of osteoblasts, leading to decreased bone formation. And sclerostin stimulates the production of rank ligand by osteocytes through an autocrine function that leads to increased bone resorption. By blocking sclerostin action, Romosozumab stimulates bone formation potently and reduces bone resorption moderately. Here are the biochemical markers that were seen in the FRAME trial over a year. On the top is the P1NP bone formation marker, and on the bottom, the CTX bone resorption marker. And you can see that very quickly with the first administration of Romosozumab, you get a very pronounced increase in the bone formation marker and a reduction in the bone resorption marker. These are most prominent in the early on in the first 8 or 9 months of treatment with Romosozumab, and they wane. And towards the end of the year, the effect is much mitigated. And the second year does not produce so much of an effect on bone formation anymore. And that's why this is a one-year medication. This is a bone biopsy specimen taken from a patient who was in placebo from the FRAME trial on the left and Romosozumab on the right. This is not a paired biopsy. It's a cross-sectional assessment at the 1-year point from the FRAME trial. But you can see that Romosozumab is associated with a much better trabecular and cortical volume and architecture. And when you look at the full bone biopsy data on the right, this is, in fact, on average, what you see with Romosozumab. Trabecular bone volume and thickness are higher. The trabecular bone pattern factor is lower. That's a sign of better trabecular connectivity and microarchitecture. Cortical thickness is higher, and cortical porosity is not increased. And this is a distinction, of course, between Romosozumab and teriparatide, where cortical porosity does increase. So who are the candidate patients for the use of this powerful option? ACE has defined the category of very high-risk patients over the last few years. And I'm going to focus on these ones in blue: recent fracture patients, patients with multiple fractures, very low T-scores, very high fracture probability, and fractures on approved osteoporosis medications. Recent fractures have been shown to be associated with an accelerated or magnified risk of subsequent fracture over the next year, and really over the next 2 years. And then the risk starts to wane beyond that period of time. These data are taken from a large database of women, 377,560 women with a prior fracture. And you can see the site of the first fracture on the left, and then the subsequent risk of fracture over the next year on the graph. And so very clearly there's a lot of site variability. The spine fractures associated with the highest subsequent risk, the ankle fracture associated with the lowest subsequent risk. On average, for any of these first fractures, there's a 10% risk of another fracture in the very next year. And even for the ankle fracture at the bottom of this table, the risk is just about 5% in the first year, and that's doubled over 2 years. And that meets the criteria that Ferrari has designated as imminent risk of fracture, and certainly is still associated with a very high risk. We also want to pay close attention to radiographically diagnosed vertebral fractures. This isn't specifically discussed in the ACE guideline, but we know that radiographically diagnosed vertebral fractures act very similarly to clinical fractures. In the study of osteoporotic fracture, prevalent vertebral fracture increased the risk of subsequent vertebral, hip, and all non-vertebral fractures substantially. But of course, if the vertebral fracture occurred in the prior year, the risk is particularly high in the next year. So they're acting very similarly to the clinical vertebral fractures that I showed you on the last slide. And I think when we find these fractures, and we should be very proactive about looking for these fractures, we should consider them to be incident and treat them aggressively to prevent more fractures and their consequences. Let's now move to multiple prior fractures. I'm showing some data here from a study called the GLOW study, which was a multinational cohort of women, 55 years of age and above, all of whom reported their fracture history and incident clinical fractures over the ensuing 2 years. So you can see on the top line here, for those women who had no prior fracture, the 2-year estimated incidence of fracture was 5%. Skipping down to the single fracture line, with a single fracture, the subsequent 2-year incidence was 9.5%, almost double. But if you had 2 fractures, the 2-year incidence is almost 16%, and 3 or more fractures, the subsequent incidence was 25%. So these patients obviously meet criteria for a very high risk and imminent risk of more fractures. The Endocrine Society has defined very high-risk patients slightly differently, and they've specified women who have a T-score of minus 2.5 or below with fractures. And I just wanted to illustrate this using the FRAX tool on the left, just taking a 70-year-old woman with average height and weight and no risk factors on the left with a T-score of minus 2.6. Her major osteoporotic fracture risk is 14% over 10 years, and hip fracture risk 4.1%. But if you give her a prior fracture, her major osteoporotic fracture risk becomes 22% on the right, and hip fracture risk 6.2%. And that hip fracture FRAX probability puts her into a very high risk category, which has been considered 4.5% or higher for 10-year hip fracture probability. The Endocrine Society also has specifically delineated the number of baseline vertebral fractures and severity of baseline vertebral fractures. If you have more than one or moderate or severe vertebral fractures, you're in the very high risk category. And here I just took some old data from the Moore trial, which looked at raloxifene effect from years ago, but these data are taken from the placebo group. And you can see very clearly the relationship between the number of baseline vertebral fractures and the subsequent risk of more vertebral fractures. And this is also shown when you look at the severity of baseline vertebral fractures, moderate and severe fractures producing a much higher risk of subsequent vertebral fracture than mild or no vertebral fractures. Though note that mild also more than doubles the risk. So we absolutely need to diagnose and still treat aggressively mild vertebral fractures. So for these very high-risk patients, we have the treatment goal of reducing fracture risk rapidly and potently. This is particularly important for those women who are at imminent risk over the next 2 years. And we want to increase BMD rapidly and potently as part of that effect to strengthen bone and reduce subsequent fracture risk. So how effective is Romosozumab for these very high-risk women? Of course, you know the design of the FRAME study. These were 7,180 women with moderate osteoporosis who were randomized to receive romosozumab or placebo for 1 year, followed by denosumab in the second year and another year of denosumab in the third year. And consistent with the enrollment criteria, these women had a pretty low prevalence of vertebral fracture. It was 18%, and only 22% had a history of non-vertebral fracture. Their T-scores were low, but they had a low fracture history. And that was by design because the trial was a placebo-controlled study for at least the first year. Here are the bone density findings, very prominent increases in both spine and hip BMD. This is from the frame extension study. Mean BMD increments were 18.1% in the spine and 9.4% in the total hip, and obviously much larger than the mean BMD changes that you see with just denosumab, which is, of course, a very effective treatment, but cannot increase bone mass the way that romosozumab followed by denosumab does. And here are the main fracture data from the FRAME trial. On the left, showing a 73% reduction in vertebral fracture and a 25% lower number of non-vertebral fractures were seen with romosozumab compared to placebo. This was not statistically significant, but we know that at one of the cohorts, which was a fairly large cohort in the trial, was at particularly low risk of fracture, non-vertebral fracture at baseline. And we did not expect that to be the case. And in fact, there was an interaction between the geographic origin of patients in that cohort and the effect of romosozumab. When we pulled that low-risk cohort out, we see that there is, in fact, a 42% reduction in non-vertebral fracture in the very first year with romosozumab compared to placebo in that rest of the world population. That's consistent with some subsequent studies that have been done where, for example, Romosozumab versus placebo was compared on non-vertebral fracture based on the baseline frax probability for fracture. So you can see that, in fact, there was an interaction between the severity of the underlying osteoporosis assessed by FRAX score at baseline and the ability of romosozumab to reduce non-vertebral fractures. So if you have a very low probability of a major fracture, romosozumab really doesn't do much. Of course, that's not our target population. Our target population are the patients who have high FRAX, and you can see that there's a progressively greater effect of romosozumab the more severe your osteoporosis is and the higher your FRAX score is. And we looked at this in one other way, and this was published recently. This looks at a subgroup of patients from the FRAME trial, not the fracture subgroup, but the non-fracture subgroup from the FRAME trial, because we wanted to try to demonstrate efficacy in those patients who had very high risk, even without a prior fracture. So we used the ACE criteria of T-score and FRAX probability. It turns out that about 40% of the population from FRAME met these criteria. 68% had a T-score less than -3, 52% had a 10-year hip fracture probability above 4.5%. And we looked at the efficacy of romosozumab followed by denosumab compared to placebo followed by denosumab over 2 years in this subgroup. And here are the BMD findings. Of course, in the spine, dramatic improvements that are very reminiscent of what we saw in the full population were seen. And most importantly, the fracture data are shown here. Let's focus just on the 12-month for the moment. So for new vertebral fractures, a 76% reduction is seen with romosozumab compared to placebo. And for non-vertebral fractures, a 54% reduction is seen with romosozumab versus placebo in this very high-risk group. And of course, these risk reductions are sustained in the second year after patients transition to denosumab, and everybody's on treatment during that point. So the strengthening effect is early and sustained. Now let's move to the ARCH study, and all the patients here were very high risk. This is 4,093 patients, and they, by enrollment criteria, had to have a T-score -2.5 or lower, and at least one moderate or severe vertebral fracture, or 2 mild vertebral fractures, or they could have a T-score up to -2 and have 2 moderate or severe vertebral fractures or a recent hip fracture. So all of these patients were really high risk. The mean age was 74, mean spine T-score -3, mean total hip T-score -2.8. 96% of the patients had a prevalent vertebral fracture, and most of these were severe. In contrast, in the FRAME trial, the 18% of patients who had vertebral fracture, the majority of those were actually mild. So it's not just the number, it's also the severity. 9% of ARCH patients had a recent hip fracture, so a very high-risk population. And these women were randomized to receive romosozumab or alendronate for a year, followed by alendronate for the remainder of the trial in both groups. So the alendronate group continued, and the romosozumab group transitioned to alendronate. And here are the main findings. First, looking at vertebral fracture over 12 months, you already see a risk reduction, and that's sustained and maybe even broadened over 24 months. And remember, we're looking at alendronate in pink here and romosozumab in green. There's no placebo group, so we're showing the benefit of romosozumab beyond the benefit of alendronate. And at the primary analysis point, which was at just under 3 years, we see a 19% reduction in risk of non-vertebral fractures and a 38% reduction in risk of hip fractures in those patients who began with romosozumab and then transitioned to alendronate, compared to those women who began and continued with alendronate only. And of course, the bone density changes were also quite marked in women who began with romosozumab and transitioned to alendronate, though note that the BMD at the end point in this trial was not quite as large as the BMD that we see when patients follow romosozumab with denosumab from the frame extension study that I showed a few minutes ago. Now, what about the very high-risk patients that are those women who have been on bisphosphonates and who have fractures? And we have a specific study that addresses this also. That's the structure study. And this study was designed in part to try to investigate or to try to determine whether romosozumab could do a better job than teriparatide in women who transition from bisphosphonates, because much of the data, and some of that was generated by me and other data by my colleague, Paul Miller. A lot of the data showed that when you transition from a bisphosphonate to teriparatide, you would actually get a decline in bone density of the hip, at least during the first year. Then it starts to turn around. But of course, that's not the best effect to see in women who are at imminent risk. So a woman who is on alendronate and has a fracture while on alendronate might not benefit, especially early on, from going on teriparatide. Could we maybe get a better result if we transition those women to romosozumab, based on the fact that romosozumab has such a prominent stimulatory effect on bone formation and the anti-resorptive effect, in contrast to teriparatide, where the bone formation is very potent, but it's based on opening up the remodeling space, stimulating bone remodeling and bone resorption. So very different effects. And in this trial, the mean age was 71.5. The patients had been on an oral bisphosphonate for at least 3 years, and specifically alendronate, the year prior to screening. In fact, the median alendronate duration was 6 years. The T-scores were -2.9 in the spine, -2.3 in the total hip at baseline. And all the patients had a history of non-vertebral fracture after age 50 or a prevalent vertebral fracture. And here are the main findings. When you look at just a DEXA BMD of the total hip on the left or the spine on the right, you can see what I described, that in the hip, patients decline on average with the transition to teriparatide. That's significant at both 6 and 12 months. In this trial, though it's only 0.5% below baseline at 12 months. It starts to come up after that. That was not shown in this study. In the patients who transition to romosozumab, though, you see a progressive increase from 6 to 12 months in total hip. So qualitatively and quantitatively, a very different result. In the spine, both groups go up, but the BMD increase is, of course, much larger in those patients who were transitioned to romosozumab compared to teriparatide. When you look at the volumetric BMD of the hip region, you get a little bit more information. The integral volumetric BMD on the left recapitulates very well what we saw with DEXA in the total hip. A decline with teriparatide that's significant at 6 months, and in contrast, an increase with romosozumab. On the very right, the trabecular volumetric BMD goes up similarly in both groups. Again, it's larger with romosozumab than teriparatide. But the big difference is in the middle. That's the cortical volumetric BMD, where you see a prominent decline with the teriparatide-treated patients, in contrast, an increase in the romosozumab-treated patients. And ultimately, this leads to a difference in bone strength that is assessed by finite element analysis using the QCT data. And you see that for teriparatide-treated patients, there's actually a decline at 6 months. By 12 months, it's indistinguishable from baseline, trending back toward baseline. But certainly there's no increase in hip strength in the teriparatide group that transitions from alendronate here for the whole first year. And in contrast, there is a strengthening effect that we see with romosozumab already at 6 months. So in this group of patients, we have clear head-to-head data showing that this is that romosozumab is a better approach than teriparatide. We know, though, that treatment sequence is important, and if we had the option to treat as first line with romosozumab, it is the best option. And if you focus on the hip BMD gain over 1 year on the left, you see the first two studies, ARCH and FRAME, where romosozumab was given as first therapy, BMD increments averaging 6 and 6.2%, whereas after alendronate, as I just showed you in the structure study, the mean BMD increase was about half that, 2.9%. And after denosumab, the transition produces a BMD increase, which is even smaller and actually not quite statistically significant. So even though we get a much better effect of romosozumab after bisphosphonate than we do with teriparatide after a bisphosphonate, it's still best if we can use it first. Of course, we have to be mindful of the safety issues that we are aware of with romosozumab. You can get some injection site reactions. Those are usually mild. Hypersensitivity has been described, often an allergic skin reaction, and that is a problem because it can progress to a more serious allergic reaction, and patients who develop that, it's quite rare, but if it happens, they should be discontinued. Hypocalcemia can be seen. Certainly it is not as prominent as can be seen with denosumab, and Paul is going to discuss that obviously in the renal failure patients. The antibody is immunogenic, so it can create antibodies formed to it, but those antibodies don't neutralize the effects, so that you don't need to think about measuring these. In terms of the very rare adverse events of ONJ and atypical femur fracture, there was one case of each of these from the FRAME trial that met criteria. But there were mitigating circumstances for each of these that can explain what happened and why. In general, we would not expect the level of anti-resorptive potency in romosozumab to actually be associated with these very, very rare adverse events. But because of these two cases, it is in the label. Of course, when we treat patients with romosozumab, we're going to put them next, after they finish the romosozumab, on an anti-resorptive drug that has these very rare adverse events associated with it. So we kind of need to discuss it with our patients regardless. And then importantly, The box warning for romosozumab comes from the finding of MACE, the composite term that stands for major adverse cardiac events that include MI, stroke, and cardiovascular death. That composite endpoint rate was higher with romosozumab than it was with alendronate in the ARCH trial. There was an imbalance that was statistically significant, 2% with romosozumab versus 1.1% with alendronate, and a hazard ratio that was 1.87, though a fairly wide confidence interval there. So the estimate of the actual risk is not so clear. But importantly, there was no imbalance in MACE rate with romosozumab compared to placebo in the FRAME trial. So we have a lot of uncertainty about what this means, yet we want to follow the regulatory guidance that suggests that we not treat patients with a recent heart attack or stroke that is within the last year. We don't want to treat those patients with romosozumab because their underlying risk of another event is so high that it doesn't make sense to think about anything with any potential to increase that risk. But that should not disqualify patients with remote mild events or cardiac risk factors. Of course, we're always looking at trying to balance and choose patients where there's a high potential benefit and a low potential risk. So in summary, patients at very high risk require a rapid and maximal fracture risk reduction, and romosozumab stimulates bone formation and suppresses bone resorption to a more moderate degree, improves bone mass and microarchitecture, improves BMD more than alendronate alone, and reduces fractures more than placebo or alendronate. In patients on bisphosphonates, transition to romosozumab improves hip BMD and hip strength more than transition to teriparatide. Treatment sequences with romosozumab first, followed by anti-resorptive agents, improve BMD more than the reverse sequence. And hopefully, I've illustrated how effective romosozumab is in treating patients at very high risk for fracture. And again, I thank you for the opportunity to speak at this very happy occasion.
Thank you, Professor Cosman, for a lovely talk covering all aspects of romosozumab. Not quite all. I now request Professor Miller to deliver his talk, and at the end of both the talks, we'll have a discussion.
Can you hear me? You can hear, yeah. Can you hear me? Okay. Is Monique going to put my slides up?
Wrong set.
disease. So I guess this is the one I'll tackle first. Next slide. Next slide. Yeah, so the FDA, let's go back. Can you go back? Yeah. The FDA recently added a black box warning for the increased risk of severe hypocalcemia in patients with advanced chronic kidney disease, stage 3B or lower, taking denosumab. Next slide. Just to give you a little handle again on the different stages from stage 1 to stage 5 or 5D. 3B, would be 30 to 40 EGFR, estimated glomerular filtration rate of 3B would be this group here. Next slide. I only put this in just because of the fact that I wanted to make you a little bit aware of some of the limitations of EGFR. On the left is the EGFR estimated glomerular filtration rate using the MDRD equation, and on the right is the same using the Cox-Gault. The line of identity is the GFR determined by insulin clearance. And you can see that there is an association that's significant with looking at EGFR by the best method and EGFR by a calculated equation. But on the other hand, there's a fair amount of scatter around the line of identity, which means that you'll have some patients who have EGFRs of 30 and a creatinine clearance, for example, of 60. So when you make decisions about either classifying people or making clinical decisions based on EGFR, which was not the intent of it ever be used by the National Kidney Foundation, if you have any concerns at all, I would do a 24-hour urine for creatinine clearance. It may make your decisions a little easier. Next slide. So the old label for DMAB was, quote, in clinical studies, subjects with impaired renal function were more likely to have greater reductions in serum calcium levels compared to subjects with normal renal function. In a study of 55 subjects with varying degrees of renal function, serum calcium levels below 7.5 milligram per deciliter or symptomatic hypocalcemia were observed in 5 of those 55 people. These subjects did not receive supplemental calcium or vitamin D ahead of time. Then in a study of 4,550 postmenopausal women with osteoporosis, the mean change from baseline in serum calcium 10 days after polio injection was minus 5.5% in subjects with creatinine clearances below 30 versus 3.1% in creatinine clearance above 30. Next slide. So now the new label, I don't think it clarifies it very well. The new label says to minimize the risk of hypocalcemia in patients with advanced chronic kidney disease, evaluate for the presence of chronic kidney disease, mineral and bone disorder with intact parathyroid hormone, serum calcium, 25 and 125 vitamin D, PTH, etc. Now, one of the problems I have with regard to the sentence is the fact that we really can't define chronic kidney disease, mineral and bone disorder very easily. It's a concept. It's by K. Digo, Kidney Disease Improving Global Outcome, and it doesn't have a ICD label. It doesn't have a diagnostic code. So it has some limitations, and putting that kind of language in from the FDA and including the concept of a syndrome, I think diminishes the impact that they could have had. Consider also assessing bone turnover status, markers or bone turnover, or bone biopsy to evaluate the underlying disease that may be present. I'm a bone biopsier, and of course, Felicia's got Dave Dempster there, and people that can do biopsies, but a lot of people can't do biopsies or have them read by anybody. But they recommend monitor the serum calcium weekly for the first month after Prolia administration and monthly thereafter, then they drop it. So they don't define whether you should go to 6 months, 10 months, 12 months. Instruct all patients with advanced chronic kidney disease, including those who are dialysis dependent, about the symptoms of hypocalcemia and the importance of maintaining serum calcium level with adequate calcium and vitamin D. Treatment with Prolia in these patients should be supervised by a healthcare provider who is experienced in the diagnosis and management of CKD, MBD, which has no diagnostic code. I think in the real world of medicine, what we're going to do is make sure that these people are not calcium or vitamin D deficient, and that will mitigate some of this. Next slide. You got a next slide there, Bruno? So actually, Michael Pausianis, Michael is a nephrologist at Oxford, and I recently published an article in the American Journal of Kidney Disease on trying to put a definition to this issue of incorporating osteoporosis into the spectrum of CKD, MBD. And I think that I think the concept is an important one, because if that's true, then you may treat the patients who have the combination of bad osteoporosis with fractures and some other form of renal bone disease. You may treat them differently than somebody with this osteoporosis without having any CKD. Next slide. So what is the basis for the label change? There were two studies. FDA study number 1, and you can look at all of these in the article by Bird in 2024 JAMA. Severe hypocalcemia with denosumab among older female dialysis-dependent patients. So this is not your 4, or this is the 5D. In this cohort study of 1,523 dialysis-dependent subjects receiving Prolia versus 1,281 receiving oral bisphosphonates, the incidence of severe hypocalcemia was defined as less than 7.5 milligram per deciliter at 12 weeks, was 41% with Prolia versus 2% with oral bisphosphonates. In most cases of severe hypocalcemia occurred during weeks 2 to 5. And if a baseline serum calcium was less than 7.5, more severe hypocalcemia was observed. Next slide. Study number 2 was severe hypocalcemia requiring emergent treatment, which was either hospitalization or urgent care, and defined with a serum calcium of less than 6.5 milligram per deciliter. And U.S. Medicare patients, 495,000 on Prolia, 890,000 on bisphosphonates, 242 with DMAB, 20 with bisphosphonates, had an emergency hypocalcemia. It's interesting that it peaked at week 2, but it still is possible out through week 10. So the idea of monitoring over a period of time, it looks like at least you ought to go out 3 months. Next slide. The early onset of severe hypocalcemia following DMAB administration aligned with the expected nadir observed in patients with normal kidney function after approximately 10 days. Limited data among dialysis-dependent patients suggests that the calcium nadir is more varied, typically presenting in the first 2 weeks, but up to 2 months in some patients. Next slide. So I think it just goes back to some of the basic biology of denosumab. As a monoclonal antibody, it's rapidly metabolized in the reticular endothelial system. And so when you stop it, next slide. On the left-hand side is the serum CTX. The yellow is patients who received lidernate, the red DMAB. And if you take a look from the baseline, the CTX drops very low within the first month. But then if you stop DMAB, you see the rapid increase in bone remodeling, not only back to baseline, but overshoots baseline. And I think that this increased remodeling and is potentially responsible for some of the weakness in the bone that can be seen with avoiding DMAB for more than 2 months from Steve Cummings' data. Next slide. So it's interesting that in the Freedom trial that led to the DMAB approval, there's no data on PTH. This is a ripe opportunity to see what happens in normal people to PTH because it goes up, but in terms of the magnitude or the duration, it wasn't. Next slide. Now we do have some data. Next slide. So on the right-hand panel, this is a paper that we published in the JCM 2016. This is patients giving PTH given PTH levels seen here after Prolia or reclass. So the greater magnitude at month 1 peak is after PTH after Prolia. It's much higher than the reclass, and it stays that way for many months. So the PTH goes up, and this is in people who have normal GFRs. This is the population of otherwise normal people. You see the magnitude of the increase in PTH is far greater than the reclass. Again, I think mirroring the greater reduction in bone remodeling. Next slide. So here was some ideas from real world experience. The worst case scenario in terms of the drop in serum calcium is about a 2-point drop in total calcium. Thus, if a patient starts with pre-Prolia with serum calcium 9.5 to 10, they will drop to 7.5 to 8 and remain asymptomatic. If they start at 8.5 to 9, they will drop to 6.5 to 7, and they may become symptomatic, paresthesias, carpal tunnel spasms, or even seizures. In stage 5 DCKD, 15 to 20% will drop by at least 2 milligram per deciliter. Charles Ginsberg is a nephrologist at the University of California in San Diego and has a nice presentation on this. And of course, many patients with chronic on dialysis are hypocalcemic. And if they start low, if they start around 6.5 and they drop, they'll be in the hospital. In a recent Japanese study cited here, 15% will have a drop in serum calcium 2 weeks after the injection of about 1.5 milligram per deciliter. Next slide. I put this slide in here just to remind people that during the course of CKD, PTH goes up. And by the time you have a GFR of 30, it's probably increased in 80%. But they still get hypocalcemic. So the PTH is high. You give them Prolia and they get hypocalcemic, and it can be clinically significant if they start with a baseline serum calcium that's low. So why are they why doesn't this PTH response mitigate the serum calcium dropping? Next slide. There's a skeletal resistance in CKD to PTH, despite the fact that the PTH can be 500, 600, 800, picogram per milliliter. you still may have people that are significantly hypocalcemic. And recently, in this review that I cite here, it talked about the fact that many receptors, PTH receptors, may be less responsive, let's say, in uremia. A certain amount of the amount of elevated PTH to CKD, I would say, may be adaptive to blunt the development of adenotic bone disease. Elevated serum phosphorus, in part, explains the PTH resistance, and so does the elevated sclerostin. Downregulation of the PTH receptor is a consequence of being exposed to high PTH. So this is probably, I'm trying to get a handle on why they get hypocalcemic despite having very elevated PTH. And it goes to these PTH resistant ideas. Next slide. So I think the unknowns are, does the baseline level of PTH make a difference? If you have a PTH in an adynamic case, which could be 100 versus a osteoarthritis fibrosis cystica, which could be 600, does the concomitant administration of calcium mimetics, if you have people that are suppressing PTH already with calcium mimetics, are those people with protein going to have a more dramatic response? And I think that this needs to be studied. Sensipar to inhibit PTH production, and I think should there be a concern for stage 3B and 4? I clearly think you've got a problem with dialysis patients. You got to be very careful with them. I'm not so sure that the degree of being worried is that bad in 3B or 4. Next slide. So, published recently in Lancet Diabetes Endocrinology is a quotation. Nephrologists have seldom been engaged in treatment decisions. Only 2 to 3% of patients undergoing dialysis in the study by Bird received treatment from a specialist in nephrology. As you know, many patients that are on chronic dialysis are cared for by their PAs, nurse practitioners, and the registered dietitians. This finding suggests the necessity of the involvement of nephrologists in the management of osteoporosis in patients with CKD, particularly those that increase risk of severe hypocalcemia. Next slide. What to do? Well, I think we ought to know what their serum calcium levels are, their phosphorus, their 25 and 125 and PTH before you give Prolia. You want to make sure you're getting adequate amounts of vitamin D to get a vitamin D level at least of 30 nanogram per milliliter. Consider calcitriol in those with a low 125. Give adequate amount of calcium, 1,200 milligrams a day. Advise all patients of symptoms of hypocalcemia. And here's a question. How about, would you give symptomatic patients teriparatide or abaloparatide? I don't think we have an answer to that. Again, there's going to be some resistance to it if you get a pharmacological level. And again, teach your nephrologists about these issues, because Prolia is wonderful medicine, and it is allowed to be used regardless of GFR, because like all monoclonal antibodies are not cleared by the kidney. They have no negative effect on the kidney. And so there's some guides here. Next slide. And here's some references about the next slide. Thank you very much.
Thank you very much, Professor Miller. It's time for the panel discussion. Can we have the slides, please? The introductory slides. Sorry? Okay. Yeah, I mean, that's part of the panel discussion. Great. So it's time to meet our orthopedic colleagues, the experts who've traveled from all over the country to be here at the launch of this very exciting new molecule, an event started with the presence of two stalwarts from across the seas. We have Dr. Sunil Marva from Gurgaon with us, who's one of the best-known orthopedic surgeons in that area with a particular interest in osteoporosis. And I'm sure Sunil will have opinions about treatments and combinations as we go along. So Dr. Marva, welcome. Next. Dr. Chhabra is also from Delhi NCR, and he till recently was the chief at the Spinal Injury Center, which is a center dedicated to spine injuries and has tremendous experience in surgery of the spine and associated areas, and now heads a new center at the Sri Balaji Action Medical Institute in Delhi. A prolific writer with many publications, Dr. Chhabra is one of the known sort of spine specialists in northern India. We have Dr. B.L. Prakash with us, who's from Bangalore, so we moved down south. Sorry, did I go wrong? You can leave it there, that's okay. Don't have to thank yet. Please, sorry, go back. Yeah, this is, okay, chalo. Go back. I don't really need that, but yes. So Dr. B.L. Prakash, who is Senior Consultant, Orthopaedic and Joint Replacement Surgeon at Fortis Hospital in Bangalore. As I said, we moved down south. A lot of experience, very skilled in joint replacement surgeries, in particular in the government sector in Karnataka, has made a huge mark with his joint replacement skills. Next. Dr. K.J. Reddy, who is again from the south, but from this city itself, from Hyderabad, and he is the chief joint replacement surgeon at Apollo Hospitals, which is the premier, sort of one of the premier chains across India in Jubilee Hills, Hyderabad. He's also a professor at the SVS Medical Institutions at Mehboob-Nagar, Telangana. He has a fellowship in advanced joint replacement surgery. He has the FAMA Asia GCC Award for Excellence in Leadership and was adjudged the best orthopedic surgeon by the Times of India survey in 2019. Next, please. We have Professor Ram Chadha, for long one of the people who's driving the treatment of osteoporosis among orthopedic colleagues in India. Professor Chadha is a consultant orthopedic spine surgeon at Leelavati Hospital, also at Jaslok Global and Hiranandani Hospital from the metropolitan city of Mumbai, with a long experience, vast experience of more than 30 years. And currently, he's president of the Indian Orthopaedic Association, which is actually a huge association and a very powerful and important association in the country. He has, used various devices and techniques, including titanium implants, about which he has published also. He has received the J.B. Modi Gold Medal for Neurotrauma. Next, please. We have Dr. Abhay Nene, who is also from Bombay, an exceedingly well-known spine surgeon from Bombay, associated with multiple hospitals, and a specialist in minimally invasive spine surgery. Numerous publications, Educator of the Year title by the AO Spine 2018. Dr. Nene and Dr. Chadha are from Bombay and both are renowned spine surgeons. We now move a little up north from Bombay. Next, please. To Dr. Bharat Dave, who also has been at the forefront in promoting osteoporosis treatment, especially in patient awareness and education activities over the years. Dr. Dave is also a spine surgeon from Ahmedabad, Gujarat. Again, very experienced and also a pioneer in the utility of ultrasonic bone scalpel in cervical corpectomy and laminectomy, whatever that means. Okay, so he has authored many books, and I think he's won the Shaleen Manav Ratna Award in 2022. But importantly, as I said, he's deeply involved in patient awareness and education, has made a huge contribution in that area too, in addition to his surgical contributions. Next, please. We have Dr. Vinish Mathur, erstwhile colleague when I was at Medanta Medicity, a well-known spine surgeon from Delhi, NCR, Gurgaon. Huge amount of surgeries, primarily interested in adult spine surgeries with minimally invasive techniques. I guess all leading spine surgeons are now into minimally invasive spine surgery. And he has been awarded research fellowships by the ICMR and the Rotary Club of India. And I think we now reach the end of the list, but not the least, Dr. B.S. Murthy, who is again from Delhi, and he heads the Dharamshila, one of the large hospitals of Delhi. He heads the orthopedic division there, and is an expert in joint replacement, arthroscopic surgeries of the knee, shoulder, ankle, has a particular interest in osteoporosis, has done several fellowships, including in Singapore, Australia, USA, Germany, and UK. So we have quite a star-studded lineup of experts here. What we'll do is I'll go through 3 or 4 slides to just recapitulate the Indian Society for Bone Mineral Research Guidelines, which were published in 2021. A lot of them are expert opinion because India-specific data was not available for everything. But that's a general guidance just to help people choose treatments. Can I have the slides, please? And meanwhile, I request my colleagues on the panel, to comment on the guideline, I mean, what they do, in those situations and where they differ in their practice. And second is to think of whatever discussion they want to have with the learned experts from the US. So, next slide. Next slide, please. So, the principles of management, next. So, one is to maintain the 25D always. We start with that. Nowadays, in patients with bone disease, there is sometimes overuse of vitamin D also. Anything over 20 is good. Maybe in patients with osteoporosis, we want to go above 30, but there is no reason to push for very, very high levels of vitamin D or use very high doses. Very important to maintain optimum levels. Next. And typically in India, numerous studies have shown that 600 to 800 and those kind of doses don't do it. If you want to maintain levels of 20 or above, you need at least 1,000 and often 2,000 units of vitamin D per day. Next slide. And of course, there may be higher doses necessary in different, that's the usual guideline, obesity, malabsorption in the very elderly. Next slide. You maintain calcium intake. Again, discussed the average calcium intake in India in the last national survey was about 420 milligrams per day, which with lot of variation between urban, rural, north, south, east, west. So yes, we need to maintain adequate calcium intake. And as I said, we are all aware, vitamin D, I already mentioned, is very important and deficient in most Indians. The usual things about alcohol, smoking, and active lifestyle, which all of you are aware of. Next. So what happens to patients who come with vertebral fractures? Now, we know that all the anti-osteoporosis medications work in this scenario. I mean, they're licensed primarily on their ability to prevent vertebral fractures. In India, often teriparatide is used as a first-line drug or is recommended by the ISBMR, and we'd like to have your thoughts on that, simply because anabolic agents work best in treatment-naive patients. They work after bisphosphonates also, but they work best initially. And teriparatide, if patient is willing and cost is manageable, which it is in most cases nowadays, teriparatide is a recommended treatment by the ISBMR. 24 months, always with surgeons. Sometimes surgeons lose sight of longer-term treatments. 24 months and followed by anti-resorptives. And however, if patient doesn't want teriparatide, intravenous zoledronic acid or denosumab are also effective options. So this was written 3 years ago, this guidance. Since the protocol for discontinuing denosumab was not firmly established at that point, often the first therapy that people were used to was zoledronic acid. So that's why, because the question about how to take patients off denosumab, which we'll discuss with our experts, was there. And as I said, this is 3 years ago, and studies were just coming in about use of bisphosphonates in that scenario when you're taking people off denosumab. So often in patients with fractures, zoledronic acid for 3 years, maybe extending to 5 years, was the first choice, and then subsequently patient may move on to denosumab if required. And of course, oral bisphosphonates do continue to work, no question about that. Now, I think we've, next. What about those who come with hip fracture? We thought that intravenous zoledronic acid, the society thought would be a very good choice, given the fact that 6 month sort of rigidity is not there, and many of our patients may not come back for 1 year, 1.5 years, or whatever, after the first 1 or 2 visits. And giving an intravenous zoledronic acid, even when the patient is in hospital prior to discharge, is something we have been partially successful, but not completely successful in implementing. One of the fears, of course, being the flu-like reaction and fever that happens in a patient who's about to be discharged and all that. So nevertheless, that's the strategy. Denosumab is also a good choice, but more and more surgeons, as I'm aware now, are opting for denosumab as first choice, even after hip fracture, even in the hospital. So teriparatide, the ISBMR felt that is not the first choice in someone who's had a hip fracture. Can be used, works, but it's not the first choice because randomized clinical trials on hip fracture alone are limited with teriparatide. Next slide. Now, without prevalent fractures, very quickly, bisphosphonates are generally agents of choice. Next, weekly oral in patients, are fine, but you can use intravenous zoledronic acid also, or you can use any of the antiresorptives, right? And we use teriparatide once in a while when the bone density is really low, like below minus 3.5 T-score, and all the patient hasn't had a fracture, risk is very high, and in those cases also, the society recommends teriparatide can be considered. Otherwise, you can use for high-risk individuals. A lot of patient discussion is involved, and depending on the patient convenience, you can use that. Next slide. So I think oral bisphosphonates for those who have milder or moderate risk for fractures. That's the usual recommendation. But a lot of Indian patients don't tolerate oral bisphosphonate. And then we have to resort to intravenous bisphosphonate or to denosumab. Next slide. I think that should be it. We didn't recommend combination therapies much, at least in 2021. Lack of data on reducing fracture was a challenge. Very interesting data from data switch and other studies, and data, the study itself is data. But that was primarily on bone densities. So the combination therapies is used based on clinicians' judgment. A lot of clinicians do like to use combination therapies, but they are not recommended like as a first-line drug, except in some patients with imminent fracture who are at very high risk. Combination therapies can definitely be considered. I think that should be the last. Yes. So just to give a background about what kind of practices we have been following, let me start from my right first, from Professor Ram Chadha. What are your thoughts, sir, about, and what is your practice actually? That's what we want to know.
Thank you very much, Dr. Mittal. I would suggest that you also be seated so that we can have an open discussion rather than you stand the way through.
Thank you.
First and foremost, I appreciate that what has been shared is the gist of practice where majority of us would tend to agree. We may have a slight personal touch to it, which may be a little bit different, but I think it's fairly fine. A few of us may indulge in combination therapies more aggressively than what an endocrinologist may mention. We are very aggressive orthopedic spine surgeons, but a few of us may still go the slow way that you do. Any which way, what my basic query and question today would be that we discuss what we've just seen. But what I wish to know from everybody here, the elite colleagues of mine, where do I place my Romosozumab? I am very clear today that I use bisphosphonates sparingly. I use the new kid on the block, which is denosumab, the monoclonal antibody, very aggressively, because we as orthopedic surgeons have a very large number of patients who are either vitamin D deplete or challenged as far as kidney function is concerned. And we are happier having a kidney-friendly medicine, so we use denosumab. And we do use teriparatide very aggressively. So we are using these three molecules. And if I look at the longevity of each of these, we have used drugs like bisphosphonates for a maximum of 10 years with 2 treatment holidays. We have used teriparatide for a maximum of 2 years in India as of today. A few of us may have gone beyond. And we are told that we can use denosumab for a maximum of 10 years. In this situation, we're looking at 22 years on a maximum as far as a postmenopausal woman is concerned. That means in India, we're looking at women up to the age of 72 to 75. Where do I place my Romosozumab? If I have a treatment naive patient, 1. 2, I have a patient who has completed these 22 years. And 3, the commonest scenario, somewhere in between, where they've either taken bisphosphonate or taken bisphosphonate followed by teriparatide, or maybe a few years of denosumab. That's where I am putting the cat among the pigeons. That's it.
So I think it'll be nice if Professor Cosman could comment on that. Where would you play? I mean, you already explained where you place Romosozumab, but in the light of all these therapies being available and everyone having experience with them, where would we insert Romosozumab into this? You're muted, I think, Felicia. You're muted. Can't hear you.
Dr. Cosman, please unmute. Thank you.
I did unmute. Can you hear me now?
Yes.
Yeah. I'm very happy that you posed this question, because I have always been interested in long-term treatment strategies. And you're absolutely right. When we diagnose women at the time of menopause in the early 50s, we might have 40 plus years to consider treating. I think for early postmenopausal women, we should not forget about the use of estrogens. And then raloxifene, both of which maintain bone mass. Raloxifene has not been shown to reduce the risk of non-vertebral fractures, but it certainly reduces the risk of vertebral fractures. So for women who are not having bad menopausal symptoms at that stage of life, it can be an effective treatment, especially if it's primarily a spine BMD issue, no fractures, obviously, we're talking about. Estrogen is extremely effective at preserving BMD and reducing fracture risk. So these agents for the younger women still make sense. Once you're in the mid-60s and beyond, we need to stratify patients by the level of risk. And that's why I was kind of focused in my discussion this morning or this evening for you about the very high-risk patients. So for very high-risk patients, at least the IOF, the ACE, Endocrine Society, the BHOF in the States have all advocated for the use of anabolic agents as first line. And so that includes either romosozumab, teriparatide, or abaloparatide, and all are very useful. And I think teriparatide and abaloparatide might be particularly effective in patients where the primary issue is a spine issue, vertebral fracture, BMD in the spine very low, and hip BMD preserved. Whereas I think romosozumab is probably a more appropriate agent when the patient is has osteoporosis and is at high risk across the entire skeleton, has already had cortical fractures or hip BMD is quite low, because in fact, romosozumab is definitely more capable of improving BMD faster and to a greater extent in the hip region than teriparatide or even abaloparatide, and is certainly equally effective, at least, at improving the spine strength. So I would position in my view, the anabolic agents for the very high-risk patient, and as defined by either ACE or Endocrine Society or both, I think that the PTH receptor agonist therapies are appropriate for many of those women, and romosozumab is appropriate also for all of those women.
And where later in the course of therapy would you consider romosozumab? This is initiation of therapy, right? What about later? Someone's received bisphosphonates, received denosumab. Where would you place it there?
Well, so in those patients, I think the structure study really gives us a good answer. I mean, I think, look, this is really hard evidence. Head-to-head study of teriparatide compared to romosozumab in just those patients who've been on a bisphosphonate transitioning because of high risk or very high risk. Romosozumab is superior. There's no question about that. And so I think for patients on bisphosphonates who need other drugs, we should go with romosozumab. Now, if it's been 3 years, 4 years, 5 years since they've been on a bisphosphonate, then I think they're kind of more like a treatment naive individual, and you could consider all therapies as kind of like starting again. We don't really know how long, though, you have to have been off of a bisphosphonate in order to get back to that kind of treatment naive state. But that's the way I would view it. And we didn't talk so much about transitioning from denosumab to romosozumab because there's just not that much data. We know that denosumab to teriparatide is not a good switch. That was shown very clearly in the data switch trial, Ben Leader and colleagues, as you mentioned. But for patients transitioning from denosumab to romosozumab, the data are better, definitely. The data that we have are from the phase 2 extension study. They show at least stability of hip BMD when you give romosozumab, and spine BMD goes up nicely, about 6%. So not as high an increase as you see in treatment-naive individuals getting romosozumab, but certainly better than teriparatide. I still think that transition is one that we need to figure out how to optimize, and probably supplying some additional anti-resorptive when you come off of denosumab is appropriate at the same time or soon afterwards, starting romosozumab. So romosozumab is better than teriparatide upon transitioning from an anti-resorptive. I think this is mechanism-based. I think that moderate anti-resorptive activity and the very prominent pro-formation activity, which is more modeling-based, it doesn't require an open remodeling space, is the explanation.
Chavda, please.
In our practice, I've been, like Dr. Ramchadda said, using denosumab extensively. But in India, we also often need to look into cost considerations. And their use of bisphosphonates does come in, whether intravenous or oral, because they are substantially lesser priced than denosumab. For severe osteoporosis also have been using have been using teriparatide, but many people for compliance or preference reasons would opt for denosumab. And I think denosumab has been increasingly been used in my practice, at least, in addition to the bisphosphonates. My questions to the panel and to our esteemed faculty from abroad would be, one, I was very surprised to learn that the dose of Romosozumab remains the same irrespective of the weight of the individual. So what are the pharmacokinetics? Why is it that the dose remains the same? To fine, that may be the same for other individuals also, but I'm a bit perplexed on that. Say frail individuals and heavy individuals, the dose remaining the same. If the dose has to be 210 milligrams, why do we need to give 2 injections? Why don't we have a vial of 210 milligram? Why 105 milligram? That is my other question. 3, India is the diabetes capital of India, of the world. And also there have been studies which have shown that osteoporosis in men may be as common, if not more common than in women. Right? The Dr. Balu Shankaran study clearly showed that osteoporosis may be more common in men. And we understand that Romosozumab is not FDA approved for men, for use in men. So what does that land into? What implications does that have? Do you still use it in men or not? Do we deprive men of this useful drug if there is some evidence in one of the trials that it could be as effective? And my last question, one of the concerns has been hypersensitive reaction. And we know that wherever there is hypersensitivity, we always give a test dose before. So why don't we try with a test dose for this drug also before implementing, even if the risk may not be very substantial, but why take the risk? So a lot of questions which tickle my mind.
Sure. So the questions are, one is related to the kinetics and the lack of influence of body weight. Who wants to take that? Yes. Yes, Dr. Cosman. To unmute again. You have to unmute. Yeah.
I don't actually know the answer. I mean, look, there was no association, with body weight in terms of effectiveness. So it's not adjusted for body weight. This is also true with denosumab, of course. It's also true with many of our drugs. The teriparatide doesn't have a weight adjustment. So I don't know exactly why that is, but it does not require weight adjustment. The question about the 210 milligram dose is because the drug solution is actually fairly viscous and requires, I think, about 1 ml to deliver the 105 milligram. And so it would just be too much. You can't concentrate it further because of this thick viscous quality, and the volume would be too large to give in a single injection. So that's why it's given as 2, and we definitely want to give the 210 milligram dose because that's what the phase 3 studies all utilized and provide all of the BMD and fracture data on. And 105, the half dose is not does not produce as large an effect on BMD. In terms of the male study, I want Paul to comment on that because he was a co-author on it. But we do not use the drug in men, although I've heard there are a few examples where the doctor has, requested authorization because they can't take anything else, and I think it's been approved for some of those men. But whether Amgen has a plan to request approval to market in men in the States, I don't know, and I don't believe so at this time. Paul, did you want to comment on the efficacy in men for male osteoporosis?
Sure. Michael Lewicki was the first author of it was a BMD study, a BMD marker study. Two small studies for fracture endpoints. BMD went up very similar to what you see in frame and arch of the spine and the P1 and P went up. So I think, if you look at surrogate markers, that should translate into significant fracture reduction. And yes, I have 2 men on it. Whoops.
And I think that, the BMD as a surrogate endpoint for bone strength is actually pretty, important, and it has been shown in the FNIH SABRE study, which was this huge meta-analysis of all these different clinical trials in the field involving all these different agents. It shows that there's no question that the BMD gain versus placebo is a marker of the effectiveness of the treatment. And we also know that BMD levels that you achieve on therapy or after therapy are predictors of subsequent risk, just as they are in people who have not yet been on therapy. So BMD really is important. And I think, of course, we all love to see fracture data, but the BMD is an excellent surrogate marker. So we can make some conclusions based on just BMD. I'm sure that Romosozumab would be effective.
Dr. Dave, please. My question to Dr. Cosman. I have read few articles, and the dose has been 70, 140, and 210. And has been given 15 days monthly and 3 monthly. So can you just elaborate why, in the studies this has been tried? That is one. And second thing, are there any specific contraindication to Romosozumab?
So the study that you're referring to was the phase 2 study, a dose ranging, study, and that, level of study is what's used to determine which dose looks like it's most effective and which one should be carried through into the big, fracture trials, the pivotal trials that ultimately are required to get a drug approved. And with Romosozumab, the 10 once monthly was the best dose. And that's the only dose that was tested in the phase 3 trials. So that's where we have the fracture data, and that's where we have the big BMD increments. So I don't think we want to veer off of that. There's no other dose that we should use. We should use 210 once monthly unless new data become available.
So I move to the last gentleman on the right side, Dr. Murthy, please.
Yeah. Thank you very much, sir, for inviting me here. I'm basically a joint replacement surgeon who does around 1,000 joints a year. And my questions usually are related to, I treat a lot of geriatric patients having rheumatoid arthritis, osteoporosis, or fractured neck of femur, and do a lot of knee replacements in rheumatoid patients. So following that, we have not talked much about the fractured neck of femur or periprosthetic fractures that occur with a lot of osteoporosis. My experience usually has been to give teriparatide for 6 months and then put them on denosumab. I presented 2 papers on this, on periprosthetic fractures, and the results have been good. So should I change to Romosozumab, or should I continue with my denosumabs? One, I believe this acts on both cortical as well as clavicle bones. Articular osteoporosis is very common in rheumatoid arthritis. How do you place this in rheumatoid arthritis with osteoporosis?
Well, I can try to take this one, but I think that when you look at the teriparatide pivotal trial, you see that the bone density change in the hip is delayed, in the femoral neck it's delayed, and that is consistent with the fact that you don't get an actual effect on non-vertebral fractures until after around 9 to 12 months. So that I believe the reason is because you are opening up a lot of remodeling cavities. In cancellous bone of the spine, there's such a big surface area that you can quickly renew that, but in cortical bone, it takes longer. And so I think that the effect against non-vertebral fractures is a bit delayed. So for a person with a periprosthetic fracture in the femur, I believe that, Romosozumab might be a better option because I think you could get an effect to improve strength there faster. But of course, there's absolutely no study that has been done to compare the two drugs in that kind of setting. But any time that teriparatide works, it's possible that romosozumab might work better. And abaloparatide needs to be mentioned too, if that does become available in India, because it does look like it's a little bit faster in terms of its onset of action and better than teriparatide, especially in cortical bone. In the spine, they look very much the same. But in the hip, abaloparatide really seems to have an advantage, both in terms of BMD and rapidity of reduction in risk of non-vertebral fracture. And I think that's probably because it's not as pro-resorptive. It doesn't increase bone remodeling as much as teriparatide.
Yeah, fracture neck of femur usually is a cortical fracture, so I think denosumab will work better in those situations. That's what I think.
So before we move to the left side, a question for Professor Miller is about the use of this new molecule in patients with CKD. Where are we with that? The use of romosozumab in patients with kidney disease. Professor Miller, please.
Yeah, that's my talk.
Dr. Miller,
Well-
excuse me, if you could just switch off one of your devices, since you are logged on two devices. We are facing echo in the studio over here. Could you just switch off one of your devices and be only on one device, if it's fine? Thank you very much.
Yes, Dr. Miller, please.
Can you hear me?
Yes.
Okay, I can't see it. Yeah, the subject of my talk next, the subject of my talk is that particular issue, the use of romosozumab across the different stages of CKD. The bottom line is, yes, down to 30 milliliters a minute. There's no below 30 ml because people would not be randomized below 30. But below 30 milliliters a minute, both with regard to BMD, vertebral fracture reduction in terms of spine fractures, was similarly across different tertiles of CKD.
So you think romosozumab can be used in patients with CKD? Or should we stick to only denosumab?
No. I think that I think Romo can be used. Below 30. Sclerostin is a bad actor. Fundamentally, it's probably responsible for adenotic bone disease that we see, and other vascular issues. So given Romo, and people who are very high risk would be across, even down to 15, I would use it. But I do a lot of that off-label use because of the populations of people that I see that are very sick.
Thank you. I request Professor Marwa for his comments. Sunil Marwa.
Is this mic? Hello, can you hear me? Is this audible, my mic? Okay.
Yes.
My concept of treating osteoporosis, which I have quite a serious guy in this, is that if I need to treat a patient, I will first build his bone before I protect his bone. That's been my concept always. Now, if I get a treatment-naive patient and he needs treatment, I will always put him on PTH first, build up his bone, and then protect his bone with, last 5 years, only denosumab. Now, if the patient, while I'm building up the bone with PTH, sustains a fracture, fragility, then I would add on to that denosumab right away, and I will go on to the combination treatment because I have worked or I have studied a lot the data and data extension studies, which gives me that proof to go in for that. When I'm shifting patients who have been on other treatments like zoledronic acid and all, and I know that if I put them on PTH, they are going to drop, as you mentioned very rightly, and what the data extension studies showed for the first time. So in those cases, I always start them on combination treatment to reduce the trough which is going to come in if I'm going to treat them only with PTH. So that concept has served me and my patients well in this period. Now, because this is a new molecule which you have introduced, and I'm not used to it, so I would have some questions on it, which are that if suppose my patient has been on PTH to whatever 24 months I give minimum, and I'm still not happy with the result at the end point, which is there many times, then can I switch on to Eventy right away, or I have to give time for the patient before I can switch on to Romosozumab? That's one question. Second, if the patient is on Forteo and due to other reasons, like he doesn't like a daily prick or something, but finances is not an issue, can I switch him in between onto Eventy? Second question. Third and the last question, once I have given Eventy for a period of 1 year, and after how many years can we go back to it? Is there anything on that one? Thank you.
So the questions don't have a lot of data to answer. I wanted to just start by saying, that because Romosozumab has both the formation stimulation and a moderate anti-resorptive potential, it's kind of like combination therapy, in one drug. So you might think about moving forward, using it in place of combination therapy in those patients where you believe it's indicated. But in terms of addressing questions 1 and 2, teriparatide switch to Romosozumab has been shown only in observational data from Japan. And in those studies, it's been more short-term. One study by Abina and colleagues shows that for people who are on teriparatide for less than a year, if they switch to Romosozumab, their effect is pretty good, but it's definitely blunted compared to treatment naive. But we don't have data going from 2 years, completing a course, to Romosozumab. My concern in that situation is that we have, as you know, a waning effect on bone formation over the 2-year period. In the second year, the effect of teriparatide wanes. So it's true with all of our anabolics that, the first year is the most efficient and then it starts to wane. We don't know exactly what the mechanism of that waning effect is. We call it kind of skeletal tachyphylaxis. It may relate to inhibitors that are produced locally. It may relate to this idea that you are depleting the pool of osteoblast progenitors and you don't have enough cells to convert. You need to regenerate those. So my worry, without having any data, is that if you gave Romosozumab right after a 2-year course, you might not get the effect that you want. And likewise, if you gave teriparatide right after a Romosozumab course, you might not get the effect that you want because of the same thing, because the effect is waning at the end of the year of Romosozumab. So There are some animal studies being done to evaluate this, but we really don't know the answer at this point. I think that you can, use a bisphosphonate after a teriparatide, and then a few years later go to romosozumab. Exactly what the optimal time course is, who knows? And I think probably the inverse is also true, that you could use a bisphosphonate after romosozumab, wait a year or two, and then go to teriparatide. So I think that those options are possible. I certainly am, I believe in the use of more anabolic therapy. And now that we have 3 in the States, we're really happy, because we can use different drugs at different times, and that we should. And this goes back to the first speaker, who talked about, long-term treatment scenarios. We need to use more anabolic therapy because it's more physiologic, and it produces a bigger effect that's both architectural and quantitative on bone, and better strength on bone. So more anabolic therapy overall, and maybe a course of anabolic therapy for a high or very high risk patient every 5 to 10 years. But exactly what to use in between, and how to space and when to restart, we don't have that much data on. So we're, hopefully we'll have more information to address that in the next few years.
So before I move to Dr. Nene, what is the total duration of romosozumab therapy that is recommended, total duration?
Each course is 1 year,
Yes.
But there is no restriction on going back to it again. So we think that you can, and we think that it should be considered, but it would have to be a very high-risk patient. It has to be
obviously.
somebody who received a course, then they were on, a bisphosphonate or denosumab for a few years, and then they have another fracture, BMD is going down, in that significantly, in that case, you would consider another course of therapy.
Great. Dr. Abhay Nene, please.
Thank you for elegant presentations, both of you. It brought a lot of wisdom to us. I had 2 questions. The first was in the real life narrative of a typical patient in my practice who's got a high risk for fractures. She has already busted 24 months of teriparatide, and she's currently on DMAB, and we are struggling with the numbers. That's the kind of patient that's currently, visiting the clinic. And then at what point do you recommend us to get to Romo? Like, should we just drop DMAB and instantaneously move to Romo, or is there, some sequence to it? And my second question is more interesting. Is there any clinical scenario where you would consider teriparatide to be better than Romo?
Well, I don't think the second question I'll handle first. I don't think that that teriparatide is superior to Romo in any setting that I'm aware of. But it is very similar to Romo in the spine and for vertebral fracture, when that's our major concern, because teriparatide and abaloparatide are unbelievably good to improve spine strength and reduce the risk of vertebral fracture. You really, so, and I think romosozumab is in that same ballpark. But I think for other fractures, Romo has an edge, and I don't see teriparatide being better. Of course, it's better if you have a contraindication to Romo. And by the way, the contraindications are, allergy, and getting back to the one of the questions, what about giving a test dose? Look, we don't give test doses for most medicines. They all can produce allergies. So I think it's certainly not something that's mandatory with romosozumab. But so that got back to another questioner. But then the question about DMAB duration, You know, I think that some people who start DMAB should just stay on DMAB forever. And that's particularly the elderly patients who start DMAB. And there's no, you know, restriction that you have, nobody says you have to stop at 10 years. Because that's just the duration of the Freedom Extension Study. That's the duration of our data. But some people should just stay on, and we don't seem to see any real, bad side effects in those latter years of therapy. It looks like, it's pretty well tolerated without any major problems. Getting off is, of course, something that needs a very close attention to avoid the risk of multiple vertebral fractures. That's critical, and that requires the use of bisphosphonates. And maybe Paul would comment on, if you want to get off, and you're a patient with significant renal disease, how do you manage it? May be very difficult to do that, but. So there's, and on the, consistent with that, denosumab is a really good drug. So not everybody who's high risk should come off of denosumab and go to Romo. I think the patients who should, be considered for switching to Romo are the ones who are on denosumab but not doing so well. They've had a major fracture several years into therapy. The BMD is persistently really low. I mean, in the -3 range, or BMD is declining despite being on denosumab. Those would be kind of the reasons that I would consider making the switch. And even in those patients, if you have a fracture, being on denosumab still provides protection against another fracture. But I think romosozumab would be better. But that transition is challenging and probably would require optimally the use of both a bisphosphonate and soon afterwards Romo. And it hasn't been done. There's no data here. I'm just giving you my opinion. Paul, would you comment on that too? Because that's a really important question. Paul, unmute. Unmute.
Yeah, I'm sorry. Yeah, it's an important question because the people on long-term DMAB, and I agree with Felicia. I mean, people doing well, I'm going to keep it on for maybe forever. Why stop when things are working? And it's got tremendous safety data. But when I want to take somebody with CKD, and the usual protocol for people without CKD is to give them 1 or sometimes 2 back-to-back IV doses of reclass to mitigate the big rise. And that's work. I think Benty Langdall's got that data. So here you got somebody who, by the FDA label, is not to be used of reclass below 30, and yet they're coming off of DMAB. So what do? I use reclass. I use it off label, and I give it slow. First of all, you don't, if it's stage 4, you certainly don't want to damage the kidney at stage 4. But if you give it slow, you won't the creatinine won't change at all. When I'm talking about slow, I'm talking about 45 minutes to an hour. Just drip it in slowly, because I think the damage of the kidney is related to the Cmax, not the area under the curve. So slow it down, and that's what I do for these people. I don't trust oral bisphosphonate absorption very well in the CKD population.
So, one of the clinical things that I do is for the use of denosumab is that in older patients, it's first choice if it's a single drug. Then there is no sort of maybe not likely to need sequential therapy. So the dilemma of taking it off and giving bisphosphonate, while it still can be handled, but if someone this is not a guidance, it's just what I do, that patients 75 or above, we like to just put them on denosumab straight away, and that It's innocuous, relatively innocuous, and easy to administer, and you're not 10 years are sort of clean. So by and large, that's a thing that I practice. Dr. Vinish Mathur, please.
Thank you. Thank you. Thank you for the wonderful presentation. Now, as I see it, whatever I could take away from both your talks, the real attractiveness of Romosozumab is the speed with which you get an improvement in bone density and bone quality. I mean, some of the data seems to show that you can build up bone as early as 3 or 6 months of starting therapy, which is not there with the other drugs. Which makes me think that one of the indications I would consider using it is in preoperative patients for elective spine surgery. We do a lot of degenerative scoliosis for elderly patients, 70s and 80s. And this is just an observation, and you're free to correct me, that I would think about using this in preoperative patients, like we build them up for surgery. That is the first thing. The second thing that caught my attention was the red flag about cerebrovascular accidents and cardiac events. Now, most of the patients whom we'll be giving these drugs to are generally having some kind of a problem. I mean, hypertension or minimal or non-interventional cardiac disease is so common. So do you have any criteria in place as to who can be given this safely? Because this looks like a big red flag to me. I remember when teriparatide was introduced, there used to be a line saying it can cause osteosarcoma. And believe me, it has taken so many patients off from taking the drug, because they used to read every line of what was given on the prescription or the prescribing information. Thank you.
In terms of the cardiac issue, the restriction in the label is if you've had a recent heart attack or stroke, you shouldn't go on it. And that's a 1 year recent. And that's because, like fractures, the risk of another event is the highest right away, within the first year, within the first 2 years. And so recent events are the contraindication. All of our patients, as you point out, have a risk of cardiac disease because they're old, at least that. And almost everybody has at least one risk factor. I think as long as we're targeting therapy to very high-risk patients who need it and avoiding it in the patients who are at very high risk for heart attack or stroke, we're respecting the regulatory guidance here. Keep in mind, that the placebo-controlled trial, which is the way we normally determine safety of a drug, the placebo-controlled trial showed no difference at all in these MACE events. And even in the ARCH study, where there was an imbalance versus alendronate, if you included heart failure, so all serious cardiac events, there was no imbalance. It was just this 3-point MACE of heart attack, stroke, and cardiac death. So I think there's a lot of uncertainty about this, and I don't want us to avoid using, Romosozumab in many of these patients who are at modest risk for heart attack or stroke. Your other question about prepping a patient for surgery, we don't have any specific, data looking at, orthopedic outcomes like that. We have had a few clinical trials looking at fracture healing, where there doesn't seem to be any acceleration in fracture healing or functional outcome after a fracture with Romosozumab, but there's certainly nothing, negative about it. So I think the idea of trying to build up bone before a surgical procedure in a person who meets criteria because they have high risk or very high risk osteoporosis, that makes a lot of sense to me. And of course, people have been using, teriparatide in this fashion with the same limitations, no real, human data, but but certainly this idea of treating the osteoporosis prior to surgery, I think is a very good one. But we're still treating on label. We're still treating for the underlying strength of the bone to improve, and not, saying, oh, we're going to get a better orthopedic outcome, because we just don't have the data to confirm that.
Thank you. Our last two experts are there. Dr. Reddy.
Thank you. That was wonderful talks from both of you, and excellent discussion. I think we learned a lot. As a joint replacement surgeon, I think my colleague, spine surgeon, asked about preoperative role of any of these agents. We do lot of revisions, and in India, I think osteoporosis in knees and hips very common. It's problematic in the sense we get stress fractures preoperatively, especially around the knee, which makes surgeries sometimes difficult. We get intraoperative fractures because of the osteoporosis, and we get postoperative periprosthetic fractures. And recently we recognize there is a subsidence of the components, both the femur and tibia. So patients experience laxity, occasionally maybe instability. These are the problems. And I want to know whether we can use preoperatively in case of knee replacements, whether primary or revisions, while they're waiting for the surgery. As you know, in the past, most of the joint replacement surgeons were very reluctant to use any of the osteoporotic treatment in joint replacement surgery. We never used to believe that they're going to help, but now I think most of the surgeons started using postoperatively, especially in patients, rheumatoid patients with steroids and revision surgery. So I want to know this, that's my first question. Second one is in avascular necrosis of femoral neck. Recently following COVID, we get large number of avians. After cell therapy, we give them teriparatide, probably 6 months later for a period of 1 year. I wanted to know whether you have any data or any experience of Romo in avascular necrosis of the femoral head.
So I'll start, and then Paul, please help me. So in terms of joint replacements, I think that, even the bisphosphonates can help improve outcomes with joint replacement. And usually, what we see is that anti-resorptives, wherever they work, anabolics work better. And that's kind of the general rule. And that's true with osteoporosis. So the higher risk you have, the more you should shift towards anabolic. Obviously, Romo being, what we're focused on today, and the, lesser severity, maybe anti-resorptive. But I think, again, we want to make sure that we're treating on label. We want to make sure that we're using these drugs for patients where they're indicated. So if the patient really has no evidence of osteoporosis, then I don't think we should be, using these drugs, because we don't have enough data specifically addressing outcomes in patients without osteoporosis after joint replacement. But certainly the concept is right, and this also relates to prepping for other surgeries. We really need more data, because I think these drugs could potentially be very useful. Of interest, we did a study with teriparatide about 7 or 8 years ago now, in people who were about to undergo a total hip replacement. We gave them a tetracycline. We gave them teriparatide versus placebo. It was blinded and randomized, and certainly we got a pretty prominent bone formation effect in the femoral neck of patients. It was taken out, the piece that was taken out at hip replacement surgery. So the effect, on bone formation does start quickly, and I suspect the same is true with Romosozumab. So we're definitely needing more data to understand these orthopedic outcomes and how to employ these in our patients. For avascular necrosis, I have no data and no experience. Paul, do you have any? Have you ever used any of these agents in avascular necrosis?
No, I don't know that. I've never used it. I don't.
So linked to that is the use in atypical femoral fractures. We're always struggling to treat AFF whenever it happens, and teriparatide seems to have found its place there, although no one is absolutely sure how much it is helping. So does a bone-forming agent like Romo, could it potentially have a use in AFF?
So, we had this one case from Frame where, the patient met criteria for AFF, and it was a patient who actually had pain at that site prior to ever receiving Romosozumab. So, the patient should have been evaluated before getting into the trial and really shouldn't have gone into the study because she likely had the beginning of a stress fracture, an atypical fracture before she ever got it. But it's in the label, and so it's a big question as to whether you should use it in people who've already had atypical femur fracture. And I think actually, this relates back to the other question. Is there a time when you think teriparatide is superior to Romo? Probably in this setting of an atypical femur fracture. The problem is, what do you do afterwards? And, you certainly don't want to put, I think, you don't want to put these people on bisphosphonates or denosumab afterwards, because those drugs we know can increase the risk of atypical femur fracture. And so I'm really unsure, and I might advocate, continued short-term kind of intermittent use of teriparatide in that setting. So, you give 6 months, you wait 6 months, you give another 6 months, or maybe it's more, spaced out than that, but a more like a continued intermittent use of teriparatide. No data to support this at all. I'm just giving you my opinion as to what might work and trying to justify it. When I look at the data, bone loss when you stop teriparatide is not as rapid as bone loss when you stop Romosozumab or when you stop denosumab. So it's not like you're going to lose everything that you gained, in 6 months or a year. It's a slower, the loss after you stop is slower than the gain. So you might, that might be an option. I think people who have an atypical femur fracture, they're showing you that they're susceptible to this for whatever reason, and you don't want it to happen again. That's for sure. Paul, what do you think? Unmute.
No, I think you're muted, Professor Miller.
Yes. How about now? Yeah, thanks. Thank you. What I do with people who you post teriparatide or abaloparatide when you don't want to use an agent that suppresses bone remodeling, you give them low-dose recidronate, and that's 35 milligrams every other week, twice a month. And it doesn't suppress bone remodeling as much as linear. It comes off faster, and that low dose, and the low dose works to reduce fractures, both hip fractures from Mike McClung's New England paper, and the European data published in OI with Johnny's register. So it's a real challenge, but but that's what I do. Actinol 35 milligrams twice a month. Let's see what else.
Okay.
That's all.
Yes. So the last panelist, sir, Dr. Prakash, please, from Bangalore.
Good evening, and thanks for that wonderful presentation and the lively discussion we had on the new molecule and various clinical settings. And most of my questions were all answered. But one question I wanted to ask is to the Professor Miller is, you spoke about a lot about the CKD patients and with hypocalcemia. So what is the dose of calcium you recommend, or what type of calcium? When such patients comes to me, I put them on denosumab, but should I send them back to the nephrologist to choose the right dose and combination of calcium and phosphorus? That's the first question to Professor Miller.
In all due respect to my nephrology colleagues in the States, the depth to which they want to grasp metabolic bone disease is pretty shallow. So I take care of the patient. In other words, 1,200 milligrams of calcium a day, hopefully by their diet. If I have to use a calcium supplement, I'll use a single dose of Citracal.
Okay, thank you. And another question to Professor Cosman. This Romosozumab in high-risk patients with multiple fractures, geriatric patients, you start away with Romosozumab, and end of the therapy, the patient is still clinically not very well recovered or still having a pain and other things. Should we again switch to teriparatide and then later on to the denosumab? Or should we wait for some period and then switch to teriparatide and denosumab, either of the molecule?
Yeah, so it's another data-free zone here. I think the answer is one of two options. I think you finish the Romo, you go to denosumab. You're going to get the best acceleration, or not acceleration, but magnification or increase in bone density after you take a course of Romo, if you go to DMAB. So that's an option, and then just keep them on DMAB for a while. And then if you see that things are still not going well after a few years of DMAB, you can get off of DMAB using zoledronic acid and give another course of Romosozumab. That's an option. I don't think that you should go directly from Romosozumab to teriparatide, because I worry that that you're not going to get the effect out of teriparatide that you want, because the whatever inhibitors might be there are still there when you start teriparatide, and maybe that mitigates the effect of teriparatide. So I think the answer is, if you want to try to maximize what happens after the first course of Romo, go to DMAB afterwards, and then reconsider. If you're absolutely sure that you want to go for another course of Romo, or that you want to use teriparatide down the line, then it probably is better to go to zoledronic acid after the first course of Romosozumab, because your effect of any subsequent therapy subsequent anabolic therapy is going to be better if you switch from bisphosphonate to the second course of anabolic, rather than denosumab to the second course of anabolic. But always Romo appears superior to teriparatide in the setting of starting after an anti-resorptive, just after. A few years later, who knows?
In cases of major adverse cardiac events, should we clearly tell the patient that you're not a candidate for Romo? Because our scenario is such that most of the elderly people have one or the other cardiac or cerebrovascular events. So if they tell them that the chances of another event would be more than with Romosozumab than with the denosumab. So should we go ahead with Romosozumab?
I think you can still go ahead. Everybody, has a risk factor, and some calcifications. If it's more remote, if it's mild, if the risk factors are controlled, I think that's the key. Do everything we can to control the underlying, risk factors. If they haven't had a recent event, I think that certainly we can use Romosozumab and should. And in part, that's based on the uncertainty about whether there's even any risk. And in part, it's based on the fact that the risk is really a small one if it's there. And we don't want to exclude all of those patients from getting a potentially very valuable drug.
Thank you very much, ma'am. What about the one last question is, patients who are on pacemakers or who are on conductive disorders, that's a cardiac thing. And if we send them back to the cardiologist, they say we don't have any experience with this molecule. And still the patient is elderly with more than 2 to 3 fractures. Still we can go ahead with this?
I think so. I mean, look, I think what we want to know from the cardiologist is, does there appear to be, really active, ischemic cardiac disease that might give us pause? And if it's just, they had AFib, 10 years ago, they have a pacemaker because of a sick sinus syndrome, that doesn't exclude them from using Romosozumab.
Well, thank you very much, and I would like to thank the speakers for an outstanding job and answering every single query that arose from the panelists. And I'd like to thank the panelists for contributing in such a meaningful way to this evening's discussion. Thank you again, Professor Cosman and Professor Miller. You've been absolutely splendid and helped us a great deal, me and my colleagues, to understand more about this new drug, which we hope to start using soon. Thank you very much. Back to the organizer.
Good luck, and thank you for having us. And thanks for the great questions. Really, they were excellent, some very difficult, but all excellent. And thank you very much for letting us share the podium with you.
Thank you.
Can I have one final shot? I've been in practice now 40 years, and I use a lot of Evenity. It's the first drug in my history of practice that has no side effects. It's unbelievable, free of side effects.
Very nice.
Yeah.
Thank you. Thank you very much. Back to the organizers, please. Yes.
Thank you.
See you, Felicia.
See you, Paul.
Good evening. I'm Yogesh, Cluster Head for Dr. Reddy's, and I would like to propose thank you for the excellent event what we had today. Let me start as we conclude the International Speaker Program for Evenity launch. And on behalf of Dr. Reddy's, I take this opportunity to thank international speakers, Dr. Felicia Cosman, Dr. Paul Miller, moderator, Dr. Ambrish Mittal, and followed by the panel members, Dr. Abhay Nene, Dr. Sunil Marwa, Dr. B.S. Murthy, Dr. Vinish Mathur, Dr. Bharat Dave, Dr. B.L. Prakash, Dr. K.J. Reddy, Dr. Ram Chadda, and Dr. H.S. Chavda. Thank you to our medical team from Dr. Reddy's, Dr. Snehal, Dr. Monil, Dr. Alpa, our colleagues from marketing and sales, Mangesh, Akash, and entire sales team here. Great job by the event partners, Eventronics, as well as the Ortho TV, where we were hosting the event for around 8,000 virtual audience. And I'm confident that with the launch of Evenity, I think this is one more option what doctors would have to treat multiple patients who deserve these drugs, almost 3 million patients who are deserving a new drug in osteoporosis. Thank you once again for your time, commitment, and the great interaction. Thank you so much.
The pricing that you are going to put it for, that's the most important question, you know.
Akash, you want to take that? Thank you so much. We can proceed for dinner. Okay.